Dr. D.P. Sinha, who is the senior most interventional cardiologist from Kolkata. Sir is now associated with...
Bhanja sir.
Yes.
There is 30 seconds countdown. After that, we'll go live.
Okay.
Prasanjit, can you start the 30 seconds? Sir, it's live now, Bhanja sir.
Yes, yes. Good evening, all. So, welcome to our complex coronary intervention case discussion. And today, the expert panelists are Dr. D.P. Sinha, who is the senior most intervention cardiologist from Kolkata. Sir is now associated with ILS Damdam Hospital, Kolkata. Dr. Devadatta Bhattacharya, sir, who is the clinical director and senior consultant cardiologist and chief of cath lab services from R.N. Tagore International Institute of Cardiac Sciences, Kolkata. Dr. Debashish Ghosh, who is a senior most intervention cardiologist from Apollo Multispecialty Hospital, Kolkata. Dr. Ashok Malpani, who is a senior consultant intervention cardiologist from BM Birla, Kolkata. And the speaker, Dr. Pranay, who is in our state from and so we'll start the case. Pranay, are you available?
Yes, sir. Good evening, everyone.
Good. Okay, you can start and present, but we should not waste our time. And
yes,
sorry for delay from my side.
So, sir, slides visible?
Yes, yes.
Yeah. So, good evening, everyone. I will be discussing a complex PCI in ACS STEMI. So, this was a 80-year male. He presented with acute pulmonary edema and ACS STEMI. So, he was known case of diabetes of 30 years duration, hypertension of 30 years duration. No other addiction was there. And CKD stage 4. The creat was 4 at presentation. So echo was showing moderate LV systolic dysfunction with RWMA in the LAD territory and thickness was preserved. And sclerosed aortic wall was there. Thick calcium chunk was seen on the aortic wall. So you can appreciate thick calcium burden on the LAD and the proximal circumflex. So osteoproximal LAD, some 50% lesion was there. Proximal LAD tight lesion, proximal tight lesion was there. And this was the LAD, a diffusely diseased vessel till mid-distal junction. And you can appreciate multiple bends is present in the LAD. So first bend here, second bend here, third bend here. So it's a very tortuous LAD, highly calcified and diffuse disease starting from the proximal to the mid-distal junction. And you can appreciate the RCA filling through left to left collaterals. And this was the RCA. So straightforward, we have given CABG to this patient. But looking at the scenario, the surgeon was also not keen on doing a CABG on this frail gentleman. And the family also was not very keen for CABG because looking at the age, frailty and all the other aspects of the disease. So they wanted somebody to do the PTCA for this case. So we planned as an elective case, we stabilized the patient and then electively intubated once the LVEDP was reduced. And once the patient stabilized, we electively intubated and then we started with this. So as expected, because of the tortuosity, there was a difficult wiring. So we started with cyan blue and a fine cross. So initial 2-3 bends, it was easy, but the last distal bend, you can appreciate the cyan blue, it's not looking in the true lumen. So after this point, if you can appreciate the cyan blue is not looking in the true lumen. Here I will play again. See. So clearly the wire was not in true lumen. So a highly calcified vessel, that too because of multiple bends, cyan blue was not tracking into the true lumen. So the wiring took me around 45 to 50 minutes to wire this vessel. So I changed multiple times. I tried with cyan blue, then again changed it to filter FC. So finally was able to wire the vessel, took out the took the fine cross to the distal part of the lesion and changed it to rota floppy wire. So this was doing a rota ablation in a long segment, multiple bend and tortuous lesion in an old age was a challenge for me. So I started with 1.25 burr, and first time slow burring I started. This is I think fourth and fifth run. You can see that now the burr is passing clearly. Then doing burring at the midpoint. So this took some time. So after rota ablation and then pre-dilated with 2 into 15 mm semi-compliant balloon. So diffusely diseased vessel. I took a 2.25 mm stent distally and 2.5 mm stent. Before putting the proximal stent at the midpoint, I have used a cutting balloon 2.5 into 12 mm and then stented the vessel. So this is the vessel after mid-distal junction stenting. And you can see some puff of dye is here at the mid-distal junction. So nothing was going inside. I had to take a Guidezilla, deep hook it so you can see the tip of Guidezilla. Then took a 2.5 into 12 mm balloon and just inflated at low atmosphere for 5 minutes. Finished the case. That puff of dye is now slight is there, but till the end of the case it was not there. So post dilated whole of the stent with 3 NC in the upper segment and 2.5 NC and 2.75 NC in the lower segment. So well expanded stent, all diagonals flowing well. IVUS images I am not having right now, but for circumflex after pre-dilatation with 2.5 into 12 mm MC, IVUS was done and it shows a 270-degree calcium. So straightforward, we thought of using a cutting balloon only 3.5 into 12 and then going for stenting. But I kept the IVL balloon also standby because I thought if the calcium is high, I have to go for IVL, and it was a huge 4 mm vessel. So 3.5 into 12 mm IVL. You can see that upper segment is still not yielding. At least 60 pulses, 6 pulses or 60 pulses were given, total 6 cycles. And after that, still, this is the 4th cycle, and still some waste was there at the balloon. This is after 60 cycles, 6 cycles and 60 pulses. Now the waste has gone, and this is post IVL. Stented with 3.5 into 28 or something stent was there. Osteoproximal LAD, I thought of doing it, but FFR was negative, so left it alone. And this was the final result. Now you can see that dye is also not leaking now. A well expanded stent, diffusely diseased LAD. So the difficult situation with multiple bends in the LAD, highly calcified vessel, difficulty in wiring, it took around 3 hours 45 minutes to finish this case. But the patient was salvaged and sent home. But it took at least 1 to 2 weeks for him to get stabilized, and after that only we were able to send him home.
Nice case, Pranay. But one thing, just I'll ask a small question. So if he's 80 years age and LV is near about 40-45% what you have mentioned, and if whether is it possible to keep the patient in medical management if and his creatinine is poor, and because first time this patient is painted with multiple tortuous lesions, multiple stents, AKI or CKD, what are the
No, no, he was CKD, sir. 30 years diabetic
30 year
nephropathy,
diabetic.
kidney size were small on USG.
But
So
case
obviously he
your
was
case was nice, but yet you have handled the complication also very nicely with Godzilla into the deep and putting the and in tortuous lesions, your wiring and basically rota is difficult, basically, and that was also nice. And in same sitting, you did all the both LED and LCX. It is also challenging because after even
we thought
contrast
of
league also you
staging
did
it, sir.
it.
We thought of staging it, but taking a high risk patient multiple times already intubated, and also I thought if I can finish it very fast. So LED took time, but LCX was very easy, sir. LCX dilated IVL and then stenting.
How much contrast you took?
Around 250 ml, sir.
Yeah. Sir Sinha sir and Bhattacharya sir, anything to be asked to Pranay? He's ready to explain you in details. He's a very good academician also. You can ask him.
What was the baseline creatinine level?
So it was 4.
So was there any challenge of a post-procedural this CIN in this patient?
No, sir, he was already pre-procedural. Only during stabilization he was started on dialysis, sir.
Oh,
So we stabilized him first, then only we took it electively.
the patient was already on dialysis or just for this
No.
procedure?
So he presented with ACS and STEMI. Presentation creatinine was 4, sir. After 1 day of stabilization, I took for CAG and decided for CABG or medical management, but he was not getting stabilized at all. So 4-5 days he landed up in dialysis. Then the family wanted, no, we don't want CABG, and he's not getting medically stabilized. So then we took the decision of intubating it electively, doing it under rotablation and all.
Dr. Pranay, very well done. This is Dr. Devashish Ghosh.
Thank you,
How did you diagnose the ACS? That is my thing, because the patient presented with mainly heart failure, and you will have the biomarkers which will have a huge false positive results in case of a CKD. So here is basically the debate between LV dysfunction, heart failure, maybe with preserved ejection fraction heart failure or reduced ejection fraction heart failure. Is it a muscle disease or the ischemia? How do we sort of say that this is ACS and he's going to be definitely helped by revascularization procedure? Because
chest pain, sir. So acute pulmonary edema along with chest pain. So it was not only breathing difficulty, which is very common in diabetic and heart failure patients, sir. He had typical chest pain, which was radiating to shoulder along with breathing difficulty. So saturation was low, 80% around on presentation. BP was okay because he's hypertensive, and we stabilized initially with Lasix infusion and NIV, but he complains of on and off chest pain despite giving multiple antianginals.
What are the troponin? Is there enzymes and what ECG? What is the?
It was raised only. I'm not having right now because this.
No. Actually, ECG. What I'm asking just about ECG. Is it normal?
No, it was typical of NSTEMI, sir. ST depression, infralateral lead, ST elevation AVR. It was not ST elevation MI.
Yeah, I think. Can I ask a question?
Yes,
Definitely, sir.
Yeah, you see, the case was well done. My reservations are one or two. One is that when you are starting this case, since you had intravascular imaging, you should have done the intravascular imaging, and it would have helped us if we could have a look at the intravascular images, especially in a patient where you have decided to do rotablation. Because it gives you a lot of useful information regarding what strategy it should be and what burr you should choose and all that. So far as the perforation in the distal vessel was concerned, I want your comment on whether it was a wire-induced perforation or whether you noticed it after you had stented it. And the third point that I have is that you are saying that you did FFR and the FFR was non-significant, which is why you did not do the proximal LAD. But if you were to, if I was left with no FFR and to make a clinical judgment, I would have actually not stented the mid and distal LAD. I would have stented the osteoproximal LAD going into the left main, because the left main is also quite, if you look at the left main, it is quite diffusely diseased and it is tapering down from the proximal to distal. So if you have convinced yourself that the circumflex needs doing, then I think the osteoproximal LAD also needed doing. That is my impression. But you are saying that there was no FFR, the FFR was non-significant in the LAD, which makes me wonder that whether you should have done the FFR in the first place after all in the LAD. And maybe the problem was all in the circumflex. One thing you have to remember is that this patient had this disease for a very, very long time. It is not that this patient has suddenly presented to you with angina, and it is very difficult to, as Dr. Ghosh was asking you quite pointedly, very difficult to find out which is the vessel that you should be doing to relieve this patient. And
Exactly, sir. Just one interruption. That's why I was thinking that because of this diffuse disease, because already Pranay told he tried to manage initially with medical management.
Yes. What I am saying, he could have just probably, if you had the FFR, okay, if you had the FFR and if you had the luxury of doing is both the LAD and the circumflex, you could have got away with a simpler procedure. What I'm saying is it is very difficult to say by looking at just at the angiogram that which is the culprit vessel. And you are saying that the changes were inferolateral in the ECG. So probably, and I mean, your final result was very good. There is no quibble about that. It was a difficult case. You ended up stenting in a very elderly patient and the patient went home. All this is very creditable. But remember that these patients are prone to complications, as you experienced yourself. It could have gone in a bad direction. 3 hours, 45 minutes is a very long time, 250 mL of contrast. The patient could have developed irreversible renal failure and could have been on dialysis for the rest of his life. And getting a patient onto dialysis at the age of 80 years for the rest of his life, is median survival becomes very, very low. So all these all these factors, you have to just keep in mind and be very particular about doing as less as possible in these patients, because in this patient you did a good result. Congratulations, but don't try your luck with these patients. Without applying your mind very thoroughly about what to do and what not to do.
Yeah, I absolutely agreed with Dr. Devyat. I think if I was hinting towards that, could we have just stented the LCX, come out, waited whether that had improved symptoms, and do LAD if absolutely necessary? Because the LCX was not a very difficult lesion. You wouldn't have to struggle so much. So I think basically, this is an elderly patient, comorbid patient, and that is what I'm hinting to. Keep the procedure to the minimal. You just need to give him relief. You don't need to prolong life anymore in this age group.
Yeah, I mean, it is, you did a good job. You're technically good, and you deserve to be congratulated for that. But you see, we have grown old doing these things. We are a little more senior than you, and we have had far more bad experiences trying to do these things. So it is just a friendly advice from senior people that be careful.
Operation was very small, otherwise he might have landed in a problem.
Because I also thought LCX took only 15 minutes, just pre-dilate, IVL, and then stenting.
Yes.
I also thought of doing only LCX, but his RCA was C2 and that was a big RCA. So I thought only doing one vessel would not help him out. So it was in my mind of doing only single vessel and come out easily and saying that we could have done only that only. But I thought he will not make out with only single vessel, because
Yeah,
RCA
yeah.
was a
I mean, I can.
like RCA.
It is always very, very difficult. Always very difficult when you get into a situation to decide which is the culprit lesion. You know, but remember, this was there. I mean, this is not a thrombotic occlusion. You could not see thrombus. This is a calcific lesion, and it has been there for at least 20 years. I mean, in this shape, it has been there for at least 10 years. And there was nothing in the LAD that would have suggested that something dramatically wrong has happened in the last 1 month or so. So that is why it is difficult. I am not saying that I am right, because it could well be the LAD that was causing the problem. You had the FFR, you could have demonstrated it.
Second thing in sir, LAD was very tortuous and diffused almost throughout the LAD. There is disease there.
Yes.
So to do all the procedure, whatever wiring with fine cross again rota is totally difficult and might have some small perforation can possible in this type of lesions in
Yes.
calcified lesions.
Yes. Yes. I mean, that is the thing. You try to do good to an elderly man, and you end up causing a perforation. This patient could have developed tamponade. It is well managed. It is well managed. He did balloon occlusion, and often I think it was a wire-induced perforation when he was trying to wire.
Because he has used all these hardwares. That is a good
Yes.
challenge. All hardwares are useful for him.
Yes.
Thank you, Pranay. It is a very nice presentation. We can go to next presentation by Dr. Raja Nag. He is a senior intervention cardiologist from Apollo, Kolkata. I think I will request Dr. Rajan to present this.
Thank you very much. Good evening. So after that very exciting case, I will be showing you a very simple case, although not simple for me. So this is a case of ISR. I did some time back recently, and I did that with image guidance. So this is the clinical profile of the patient. He's 70 years man, non-smoker, hypertensive, non-diabetic, presented with angina of class 3 since the last 3 months on maximum medical management. So he has a long history with the interventional cardiologists and the cardiac surgeons. In the year 1999, he underwent 3 grafts with CABG with Lima to LAD and venous grafts to OM and diagonal. In 2011, he presented with ACS, and then he underwent PTCA and stenting of the venous graft to the diagonal. Again, in 2015, he again had another ACS for which he underwent PTCA stenting of the native RCA. And 2018, again, he underwent a PCI stenting of the venous graft to the OM. So these were all done in Apollo Hospital. So we have all the data with us. And the first time he landed up with me is in 2019 when he had LVF and he was hospitalized under me. So his ejection fraction was 30% at that point of time. Medically managed at that time and did not do an angiogram because his creatinine was on the higher side of 1.9. He was doing well on medical management till 2021 in the middle of the pandemic when he had severe teeth and jaw pain on mild exertion. This time he has developed atrial fibrillation, but with controlled ventricular rate. Ejection fraction was around 45% with a creatinine of 1.4. So presently his medications were all the diuretics, Aptas, Vimada, Carvedilol, and everything which was required for his heart failure treatment. So we took him up for angiogram, did a radial root angiogram. These were his native vessels. So like we can see, there is a instant restenosis, critical instant restenosis of his right coronary artery extending from the proximal edge to the proximal RCA. So this was quite tight, and there were changes in the ECG in the inferior leads only. So we did an entire graft angiogram also, all by the right radial route. So there were moderate disease of the grafts, but we thought that because it is an old graft and it's flowing, we should not tamper with it. So what would be the next plan was the question. So he had CABG already. He's a short-statured and small-built man, and would never opt for a CABG again. And that was also not in our list of recommendations. So we decided to advise him intervention of the native RCA instant restenosis with image guidance. So after one day, we discussed with him and his family members, and then decided to take him up for PCI of the instant restenosis. This time I went by the femoral route, and wiring was not difficult. So pre-dilated that with 2.5 NC balloon. So this was after the first pre-dilation. Like you can see, the stent was well expanded, but there was severe neointimal hyperplasia from the proximal edge and extending up to the proximal artery. We took reference diameters of the distal stent. The stent earlier was a 3 diameter stent, 324. So this is basics of instant restenosis we see from the autopsies. And these are the various pathological presentations of instant restenosis patterns. So mine was like type 1B. We took the reference diameters and decided that he will require a 3.5 stent at least with a length of 28 millimeter. And we are not covering from the distal edge to the proximal, but from the edge to the proximal of the RCA. So we pre-dilated again. There was some evidence of calcium from the OCT images. So we decided to do with a cutting balloon of 3.10, but it was not giving way. So we took another OPN balloon of 3.10. This time we took 2 wires, but reason being usually while withdrawing the balloon, the wire also sticks to it and comes back. We took the OPN balloon up to 40 atmospheres of pressure and did OCT run again. This was the post pre-dilation OCT. Like you can see, the previous stent was well expanded and opposed, but he has a very aggressive kind of disease. So we had good luminal gain, like you can see from the OCT images. There's some amount of calcium, but it was we could achieve good lumen with the cutting balloon and the OPN. This is a 3D render of the same image. You can see both the wires. So with that, we decided to stent with a 3.5 28 millimeter drug-eluting stent. We did that. Post-dilated with a 3.75 balloon. And this is the final result. And this is the final OCT images. The stent expansion was more than 100% with a surface area of more than 7.7. The stent was well opposed, no edges. So he was discharged of medication and is still on follow-up angina free. So treatment of ISR is basically, this is an algorithm which is showing like where we can use a DEB, where we should use a drug-eluting stent. So we know all about that. So to conclude, the management of patients admitted with instant restenosis and stent thrombosis is challenging. Challenge is not of the challenge is because these patients have a high incidence of MACE even after the second procedure. So interventional treatment means has already failed in the first instance. There is often underlying causes that led to this event. The event rate following repeat PCI, like I've said, is very high, up to 40%. OCT or IVAS or some kind of intravascular imaging should be routinely used to understand the pathological causes, pathophysiology, identify the causes of ISR or stent thrombosis, guide the treatment, and evaluate procedural results. Thank you.
Thank you. Thank you, Dr. Nath. Hello. Thank you, Dr. Nath.
Someone's mic is echoing. Dr. Rajiv Banja, your mic is echoing.
Now is it okay?
Sir, you are logging from 2 devices.
Now I think.
Perfect.
Thank you, Dr. Raj. I will request all the panelists, Dr. Ashok sir, Dr. Devasis sir. Sir, please proceed. I want to one question. Why you have leave this grafts? Because it was also a critical more than 90% lesion.
I don't think it was more than 90%. It was around 50, 60%, and it was flowing. And already the one graft has already been intervened. And because it was a flowing graft, I didn't want to intervene into that.
Previously also there was that graft was intervened.
Yes, yes.
Already the site of
my point is my culprit vessel was not the graft. The instant restenosis of the critically instant restenosis of the RC.
the graft was also, it was to the RCA or L6, which was stenosed.
LCX.
And what the ECG shows?
ECG showed some STT changes in the inferior list, but it was not very convincing. He is in AF with controlled ventricular rate.
What was the LV actually, ejection fraction?
Ejection fraction was around 45%.
What stents? What is the stent? What stent? Previously, what stent was in RCA? Now, what stent will be?
Previously, the stent was Medtronic stent, drug-eluting stent, 3x24. This time we put in a 3.5 28 Zions.
Thank you.
Thank you.
Sir, Ashok sir, please.
Raja, thank you for showing a nice case. Did you ever thought of using IVS instead of OCT in this case, because the challenge is creatinine was already 1.4?
Yes, sir. Yes, sir. Yes, sir. I would have loved to use IVL in this case.
I was
cost, sir.
No, I said, not IVS.
Yeah.
I was instead of OCT.
Yes.
Because the I was a constant in this case, his creatinine was 1.4 at the baseline and 70-year-old male. So I would have thought given a choice.
Yeah, IVAS is a choice, but I used contrast of around 150 ml. And what I do in such cases when I prefer to use OCT, I personally, there are personal preferences, sir, like you know, my preference is to do OCT. I love the images and they show the 3 layers so convincingly. Yeah. So I prefer OCT, number one. And number two, in this case, or in any case which I use OCT, I do not take too many angiographic shots. Once I take IVAS shot, OCT shot, that itself gives me a 3D idea of the lumen, the morphology, everything. So one single OCT contrast shot gives me the whole idea, sir. So that is how I do it. And after that, I do not repeat post procedure. I do not repeat after the without wire, with wire. I don't do that. I only take one shot with OCT, one contrast injection. and that too with the injector. So I don't fail, or I don't have to repeat the injection and give more contrast to the patient.
Okay.
Okay, Raja, if
Sir.
anyone, nobody else has a question, I have a question for you. So this RCA was done first in which year?
2019, sir. 19, 11. Just let me go back to it. Let me go back to it. (1999) he had CABG. 2011 he had stenting of the venous graft to diagonal. 2015 he had PTC and stenting of the RCA, sir.
Okay, so in this case,
2015.
So this is 6 years down the line, right?
Yes, sir.
So in this case, it is unlikely that this is neointimal hyperplasia, more likely that this is neoatherosclerosis. So would you like to show us your OCT images again and discuss, because that is really important.
I can show you.
And the other thing was that it was more disease in the proximal RCA rather than instant restenosis.
Agreed, agreed, absolutely agreed.
Progression of atherosclerosis in the proximal RCA, and it was very fibrotic and calcific. So let's have a look at that OCT image, the first OCT run. Yeah, so you can see that the disease is above the stented segment.
Yes, agreed, but it was peristent. It was not.
I agree. I agree. I mean, it qualifies for instant restenosis, but my point is that the stent itself, within the stent, there was not a lot of neointimal hyperplasia like the images.
No.
So just give us a look of that OCT image.
Yes, I'm going there.
The only thing, Devdatta, I want to make a comment. I do agree there was a lot of stenosis above the stent. But if you see that focal tight lesion, whenever you see a very focal tight...
Let me just look at this.
Yeah, here you see, sir.
Yes.
Here
yes.
it starts.
Yeah, just scroll it through it. Yeah, I agree that there is a that there is a focal lesion there. See, go back to that. Can you freeze it?
Yes, I'm trying to do
in that region. So freeze.
Yes,
Yeah.
frozen.
So the stent is quite well expanded here. I have no problem with the stent expansion.
Yes, I totally agree with you.
And I mean, I would think that this is more of neoatherosclerosis.
I thought it is more of neointimal hyperplasia.
Acha, go up a bit more. Go up a bit more.
Just a minute. Let me play it again.
Yeah. Oh, okay. So you have to come back again. All right. So very good. If you look at the see at the side there, and keep going. Okay, so if you follow it from distal to proximal, there is one interesting thing here. It is that the maximum amount, let's for argument's sake, I will let me just accept that this is neointimal hyperplasia. The point I'm trying to make is that look at the distal part of the stent where it is very well expanded.
Absolutely.
And look at the part of the stent where you have the maximum neointimal hyperplasia. And you can trace the stent margins since you have done OCT, very nicely traced stent margins. And what you can see here that at this portion where there is the maximum amount of regrowth, the stent is actually a little underexpanded. Do you agree?
That part also I fully agree.
Yes. So just show us once more, because all these things are important when you consider what is going to happen long term. And here you are out of the stent, and now keep playing. And here you can see that this is a fibrocalcific lesion.
Absolutely.
Really bad fibrocalcific. Keep playing. It really gets bad after this. There, can you see that calcium bulging in there?
Yes,
This is the calcium nodule bulging in,
probably.
And that is where you were having the maximum problem.
Ekdom.
Okay. I think I'm happy now that you have shown me the images. So my point is that if you were dealing with a patient who just had that tubular instant restenosis and didn't have that calcific lesion proximally, you could have probably approached it differently. So give it a good expansion there and put a drug-eluting balloon.
Absolutely.
And but what you did was quite right, because there was progression of disease and it was 6 years down the line, and it is a fibrocalcific, and you could see that calcium jutting in.
Yes, sir.
At 3 to 4 o'clock, and that is something that is not suitable for IVL. Okay.
If you see, my balloon also was not expanding eccentrically.
Yes. It is not suitable for IVL because your balloon can rupture.
Agreed.
It's a calcium nodule.
It is an eccentric nodule kind of thing.
Yes. And then, but your demonstration of that high pressure balloon, the NC balloon, and went up to 40 atmospheres. That was very good. So, in the end, I think very good result. I think my learning point from this is that when you are doing a stent, when you are doing stenting, it is very important to actually optimize at the end. That is why we keep insisting that very, very important. And it is at the tightest segment of the disease where the stent tends not to expand.
Yes.
And we accept 20-30% residual lesion, but if we take care to pre-dilate this a bit more and then take care to post-dilate it, probably the longer term results in our stenting will be better. But in your case, there was progression. I would expect that the SVG to die, as Dr. Bhanja was suggesting, I would expect the SVG graph to progress as well within the next 1 or 2 years. So watch out.
Because it was not 60%, it's definitely more than
80%. I would agree it is more than 60%.
So would you have intervened? Question is that.
It is also very difficult whether which is culprit at present, because there is no ECG, no SCT changes is there.
At least that prospectively after that he's angina free, so I would think that was his culprit.
Yes. But I mean, it is, you see, it is a difficult case because this is an elderly man and the ejection fraction is on the lower side and the creatinine is high. And so you can, for example, and this was a 20-year graft, so you can get into trouble by trying to do that graft. I accept that. And you have to take precautions when you are doing that graft. But the point is that Dr. Bhanja, I think I agree that this is a graft that will get worse with time.
Thank you. It is very nice. Can I just come in? If you had to do the graft was to the OM, I think you would rather do the native OM actually. If it's anatomically possible. That's right. Because otherwise, this graft, even if you intervene, the graft is not going to last you for more than a year.
Keep coming back.
Yeah, and I think it was a very well done case. And my take is, I think that I agree with that. I think that tightest part of the lesion, I think it was more like a new intermittent hyperplasia, and the peristent was more like a neoarthrosclerosis. Right, so I think it's probably two pathologies working together.
Thank you.
Thank you. It is very nice presentation and demonstration. Result was excellent.
Thank you, sir.
Then I will request Dr. Syed Rana, who is a senior consultant intervention cardiologist for RN Tagore. Please have your
Dr. Rana sir is not there, so we proceed to Dr. Snail sir.
Okay. Dr. Snail, he is a intervention cardiologist from NHMMI Raipur. I will request Dr. Snail to present your case.
Yes, sir.
I think Snail is there.
Yes, sir.
Yes.
Very good evening to all the moderators and panelists here. I'm happy for such a team because I was trained in Rabindranath Tagore Institute under Dr. Bhattacharya as my guide and my mentor, and other moderators from Kolkata, and I'm working in Raipur. To have Dr. Bhanja and Dr. Pranay here as speaker, couldn't have asked more better team to show my cases. So actually this is a collage of 4 cases, all involving RCA. This is different presentation of thrombus. I'll go in ascending order from a simpler one to a tougher case. So the first case, which I've titled Nothing Was Needed. This was a young man who came to us during the second wave of COVID. He was 39 years old, obese, with sedentary lifestyle, presented with the ST elevation MI in window period 5 hours. We loaded him and took him for primary, and this was his RCA. There was thrombus in mid RCA, which I can say was grade 3, and there was some embolization of thrombus to the distalmost PLV. Left system was completely disease free. There was some plaques in the ramus intermedius. So what we did is just we put him on tirofiban infusion for 24 hours, and check angio shoot before discharge showed absolutely normal RCA. We deferred the stenting and kept him on medical management, DAPT, for a year. Patient is doing well with absolutely 100% recovery of the regional wall motion abnormality in RCA territory. This was a simpler case. I'll move to the second one. This was a COVID positive case. Again, we encountered this case in the second wave, and he was a 60-year-old man, was recently diagnosed as a case of diabetes mellitus, was diagnosed as a case of inferior wall MI, and was thrombolized outside with STK. Was immediately referred to us due to ongoing angina. Window period was a 3 hours. ECG showed ST elevation in 2-3 AVF with ST depression 1 AVL and V1 V2. Echo showed hypokinesia in infero-posterior wall. There was no MR. EF was 40%. So we took him for rescue PTCA, pharmacoinvasive one, and LCX was normal. There was LAD showed some plaques distally. Left system was supportive, relatively disease free, and this was his RCA. It was grade 5 thrombus. So this was a easy sailing for us. We could pass Shion blue easily. We did a couple of export runs. We can aspirate this thrombus, and post thrombosuction, there was stenosis 80% at the crux or the distal RCA, which we stented with 3.529 biomine, and result was good. And this was the end result. So this was the 2 spectrums of thrombus. Now I'll move to the third case. The patient was discharged 7 days as he was COVID positive. We kept him for observation. His HRCT score was say around 11, which was managed with for COVID for 7 days with us. This one, the ping pong thrombus. This was quite a challenging case, which took almost 3 hours in cath lab. He was a 47-year, relatively, we can say, coronary artery disease in a young. He presented to us again with the inferior posterior wall MI. He was outside window period. He presented with the onset, say, around 24 hours. On admission, he was having sinus tachycardia. He was having no angina or shortness of breath in admission. So we did a elective angiography. This was the RCA, tortuous and completely occluded distally with grade 5 thrombus. This was the left system. There was just some muscle bridge in the mid LAD, some minor plaques and distal LCX, and some very faint filling of distal PDA from left system. So what we did, he was outside window period with no ongoing angina, so we decided to reduce some thrombus burden. We loaded him, kept him on tirofiban infusion for 24 hours. Incidentally, patient had fever post angiography, so we waited for another 24 hours and continued him on low molecular weight heparin, and took him for angio again after 72 hours. And this was the picture back then. There was no reduction whatsoever in the thrombus burden. It was same like before. So this time we decided to intervene. we did multiple thrombosuction run here. To be precise, thrice we did it. And to avail no change whatsoever in the angiographic picture there. So we decided to go ahead and plaster the thrombus with 3mm balloon. And after using balloon, we stayed where we started. There was no change there. We did a repeat thrombosuction again. And through thrombuster, we gave intracoronary trirofeban and nicorandil. And what we managed to do is we got some flow distally, but we got a thrombus. We pulled the thrombus in proximal RCA. Post this, we again did rethrombosuction. There was some flow in distal RCA, contrast tickling into the PDA. Seeing some flow, we again did a thrombosuction. But after this run, again, we occluded the distal RCA. This time we lost the count how many times we have done thrombosuction, but at that particular time only, that was the thing which was working for us. Again, we gave a intracoronary nicoran and tyrofeban, but this happened again. We pulled the thrombus this time in a much bigger load in the proximal RCA. So we did a thrombosuction at proximal segment. And as we did it, again, we occluded the distal RCA. So hence, thrombus was playing ping pong with us. So we reballooned it. And again, thrombosuction for the nth time. As I mentioned earlier, we have lost the count how many times we've done the thrombosuction. And finally, this was the result. Since we have done n number of thrombus run, what we ended up is that patient needed inotrop. He had a significant loss of hemoglobin of 2 grams. He developed mild to moderate MR, which was due to delay in intervention. RC was completely occluded, so it was a ischemic MR. So as we got some amount of flow in distal RCA, as you can see, thrombus was still persisting in distal RCA to PLV, and PLV was completely occluded distally. So we kept him on tyrofeban infusion again for next 24 hours and continued him on ecosprin, prasugrel, and low molecular weight heparin. So check angio was done prior to discharge. And this was the picture after tyrofeban infusion. As there was no stenotic lesion, the RC was completely filled with thrombus. We decided to defer stenting in this thrombotic milieu and just kept him on DAPT. Patient was on follow-up to us at 1 month, 3 months, and 6 months. And there was some recovery in the in RWM and posterior wall. There was no MR, or you can say trace MR, but there is some hypokinesia persisting in basal inferior wall. So this was the angio just before the discharge. ECG just before the discharge. And this is the fourth and last one, dilate another ray. So this was a 54-year-old male who presented to us with inferior posterior wall MI. Window period was 10 hours. He had a very strong family history of coronary artery disease. His father and a couple of brothers both had coronary artery disease. ECG showed ST elevation in 2-3 AVF, and there was RWM in RCA territory with EF of 40%. So this was his left system, which was diffusely diseased with subtotal occlusion of the LAD with TME1 flow distal to the occlusion. Distal left main at the bifurcation of LAD and LCX was deceased. And this was his RCA, a tortuous RCA, which was totally occluded in the mid segment. So as he was in window period, had presented with STEMI, we decided to intervene this RCA because LAD seems to be chronically deceased. We cannot negotiate Chion blue wire with balloon support also. We have to shift to intermediate wire and finally to whisper extra support. Through this, we could cross the RCA. We wanted to avoid too much of pre-dilatation, but to avoid slow flow in this grade 5 thrombus, or we can say angry thrombus in this tortuous RCA. But what we noted is while pre-dilating, dilating, there was significant wasting noted with the balloon. So we were forced to use sequential pre-dilatation, but lesion was not giving away. There was always some amount of wasting noted with the balloon. So after pre-dilating it with 3 millimeter, there was some flow. This was the result after pre-dilating with 3 millimeter balloon. So there was significant thrombus load, but distal RCA was flowing. So we decided to stent it. We took 4.530 onyx, and despite of sequential pre-dilatation, the mid portion of the stent was not giving away. So we went with post dilating the stent at 4 millimeter and 4.5, but there was significant slow flow, which was dealt with intracoronary tirofiban and nicorandil. And this was the result after doing the primary PTCA. Stent was not optimized properly, and there was some distal migration of thrombus in PDA and distal most PLV. So we abandoned the procedure here, and we decided to keep patient on tirofiban infusion for 24 hours. And after 24 hours, we took the patient to cath lab again, and this time there was some thrombus persisting in a branch of PLV and grade 1 thrombus in distal PLV. So we decided to optimize the stent. Unfortunately, I cannot keep a picture which can show how underexpanded the stent were, because while passing the wire through this stent, we were going behind the struts, and this happened for say around 5 to 6 times while crossing Cheyenne Blue. Ultimately, we took help of Guidezilla to cross the wire here, and after negotiating Cheyenne Blue, we post-dilated and optimized our stent using 4.5 and 5 millimeter balloon. And this was the end result. So my take home is different strategies needed for different patient with same disease. Hence, treatment needs individualization. Thrombosuction is an effective method, as ESC and ACC both agree to this, that if thrombus is more than grade 3, then GP2B, 3A and thrombosuction comes into play. Staging of the same procedure should be planned as per the demand of the case. And also for treatment of thrombus, I think medical management is the choice. Stent is for stenotic lesions. And the last one, keeping patients in long tiring cases is the key to success.
Thank you, Snehal. Very good. Snehal, your last 2 cases are COVID, post-COVID, or they are COVID positive
No,
patients?
sir. Only second case was COVID positive. Last 2 cases were not COVID positive.
So out of 4 or 5 cases, how many are COVID positive?
So one. The second case was COVID positive.
Actually, one question I will ask to all the panelists and everyone. Actually, last COVID, the second COVID wave, I did 10 plastics of COVID positive patients. And I think out of 10, 8 are influal MI. So just that's why I am correlating whether, and all are highly thrombus burden. And I did primary angioplasty almost once the patient entered to the hospital, and within window period, all took a long time, all are highly thrombotic burden, and almost all are within 35 to 45 years of age. And I have shown this set of cases to one case presentation. I didn't know actually whether other consultants are facing the same problem during COVID, whether only RCA was involved or any other are involved. Is there any experience from the audience, actually from the panelists and speakers also?
I can, this is Dr. Devashish Ghosh. I can quote a case which was actually a very senior doctor, an orthopedic surgeon, who had a CABG in March of 2021, had a CABG, and 3 months after the CABG, he had a vaccine and a mild COVID, which was not proven. He didn't do an RT-PCR, but his symptoms was very, very suggestive, and he had a vaccine as well. Prematurely, when the recommendation is you have to wait a little bit after a surgery to take your vaccine, but he did take it quite early. And unfortunately, he came back to Bath in June with an occluded RCA graft totally. He had a graft to the RCA, venous graft was totally occluded. basically the most important and the distressing point was the left main stem, which was clearly normal in the angio in the pre-CABG, had now a 90% thrombotic occlusion, and we did an OCT which showed just thrombus, and more thrombus. So I don't know whether we do not have enough data to tell us that is it a vaccine-induced event? Is it like a VTT, what we know now, or is it a So it is. I think there is definitely an increase in atherosclerotic events. You could say that COVID is a pro-inflammatory state, and we know that atherosclerosis, if you have inflammation anywhere in the body, atherosclerosis gets angrier and you will have more events. But the thing was, it was also very, very thrombotic, which you were also saying. So that's my experience. Well, I have had many other experiences with doing post-COVID primary angioplasty, but this was a very, very peculiar case.
Thank you, sir. Pranay, you have any idea about because you did a lot of cases in KR hospital. What is your experience during COVID? Not this time, last time, because I think you have also faced a lot of cases, those who are coming to your hospital having COVID positive. What is your experience about the thrombotic burden, and which MI was more? What was my experience? I have shared it was, but I have gathered it was a maximum of influval STEMI, highly thrombotic burden in young patients, and almost all positive patients, because initially we didn't do, but gradually I did all the primary plasties of all young patients. What was your experience during the last?
It was very high thrombotic burden, but with my experience, it was more of triple vessel and older age patients who were developing acute MI because of COVID illness. So whatever patients I have done, only one or two were single vessel with young patient. Like one patient was 19th day post-COVID recovery. He developed acute thrombotic occlusion of LED, and just thrombosuction was done, and then kept for 7 days of heparin and all. Then recheck angio, it was cleared. But other patients, most of them were having triple vessel or multiple lesions, and one culprit lesion was there, which was having high thrombus burden and which was the cause of MI. So one or two patients I had, which were young patients with high thrombus and acute plaque erosion or plaque rupture, which was the cause. But other patients, usually I had triple vessels and double vessel with atherosclerosis was there because of pro-inflammatory state. One of the other plaque ruptured and caused MI, and the thrombus burden was very high. So despite of multiple thrombosuction runs, also I was getting TIMI2 flow only in some cases.
But this one of the things which we are noticing in this run of COVID, that is the third wave, I have done a few angioplasties, primary angioplasties in the third wave. I think that it is different. It's different from the second wave. The second wave was what you're describing, very aggressive disease, very thrombotic disease. In the third wave, I think the thrombus burden, it looks like a barn door MI patient that we normally deal, and their COVID, the degree of illness was also less. In Apollo, they usually do, the COVID team usually sometimes do a CT scan, and they showed hardly any lung involvement. So I think the profile has changed from the second wave to the third wave. In the third wave, I think we are getting more and more our usual MI cases, and COVID is an incidental finding.
Yeah, so mostly they are asymptomatic COVID positive. We primary PCI in the night, morning the intensivist
result comes back,
RT-PCR, and it is positive.
Absolutely.
So it's like a huge flurry of patients. We are doing primary in the odd hours, and morning we come and they say this was a COVID positive patient which you have done. So it's very commonly asymptomatic RT-PCR positive patients are there, sir, now.
I think Sinha sir has joined. Please have your comments, sir, please. Dr. DP Sinha sir, please. Any comments from you?
Actually, I have done a few of COVID cases, but they are distributed to all the arteries, not specifically to right coronary or something like that. And yes, in the third wave, I have done a few COVID positive patients. But surprisingly, there is one observation. Patient comes with chest pain, the troponin is elevated. We do an angio, find the coronary arteries to be relatively normal, no intervention is required. But next day, the COVID reports come as with a positive patients. That is a surprising finding. Only troponin becomes elevated with chest pain, but I didn't find any significant coronary artery lesion. I don't know what's happening there. Is it a COVID myocarditis or something that has happened, closed, opened by the time I did an angio? That's for the panelists to say. But in the second wave, we did all kinds of operations, LAD, RCA, circumflex, all.
Thank you, sir.
Okay, Dr. Bhanja, I have one or two comments, if there is time for it.
Yes, sir. Yes.
Okay, so Snehil, I think the cases that he presented, there was the salient feature of these cases where these are really large RCAs. So they are all 3.5 plus RCAs. One of them was 4.5. So what in general, I think all of us have experienced that larger vessels, if they're occluded for a long period of time, they have a very long thrombus burden, and the thrombus burden is always greater. So if you are, regardless of which artery, if you are dealing with the RCA or with the circumflex, a dominant circumflex or a proximal LAD, and if the artery is large in caliber, in diameter, and it has been occluded for more than 12 hours, then you can expect trouble. There is a long column of thrombus, and especially this happens in patients who have TIMI zero flow. And the entire artery, although not diseased, is now full of thrombus, which happened in the cases that Dr. Goswami showed. And I think what you have to be very careful about approaching these vessels because you can make the things worse. So what could happen, and what did happen in one of their cases, was that there was a lot of thrombus which was going up and down. So it was coming, I have never seen this coming up proximally and then going distally and coming up proximally and back again. But you know, these things can happen, and you have to be careful with your export aspiration catheter. So if you are not, I think what is happening is there is a large volume of thrombus that is getting aspirated, and while you are taking it out.
Sir, Bhattacharya, sir, one thing I want just to interrupt once. Sir, I have seen this type of cases once. I will just ask you, what is your experience? These large vessels, usually they took guide inside. Total is like 7
Yes.
guide inside. If we, instead of the thrombus catheter, if we take the guide inside and took the point, what is your
Yes.
experience, sir?
Yes, I have never tried that, but I've seen other people doing it. And
Yeah,
if you are expert at it, you can do it, and you can suck the entire column of thrombus out. I've also seen this being seen in venous grafts, where there is a lot of thrombus
So
in
in
an
RCA also some.
Yes, absolutely.
I have seen.
You can actually take your RCA catheter, deep throat it down, and then
Exactly.
suck it out. So you have to be careful that your thrombus, if it is a large thrombus, column of thrombus that you're suspecting, when you're taking it out, part of the thrombus can actually break off. So the trials that they have done in thrombosuction, one of those trials, it showed that there was a slightly greater incidence of cerebrovascular accidents because this long thrombus column was breaking off and going off to the brain. So that is another thing one has to be really careful about, because what was happening in the proximal RCA, it could also happen in the brain. And when you're taking that export catheter out, it is very important to look at what is happening at the O-ring there, because a part of the thrombus could break off and stay inside that Y connector. And next time when you take your hardware in, you could just push that thrombus back in. So that is another thing. And the other thing is, when you're doing export aspiration, if your blood suddenly stops, so you get a little flash and then you don't see anything, it means that probably, and if it is a big thrombus that you're suspecting, it means probably that your catheter mouth is blocked now. And be very, very careful when you're taking these out. If you are doing a left-sided system where there is an angle between the, for example, say the circumflex or the LAD and the left main, disengage the catheter, try to make it a little coaxial while you're taking it out, because if there is an angle between the catheter and your export aspiration catheter, and when you're pulling it out, that thrombus can break off. And we have seen this, we have experienced this. The thrombus has broken off and stayed in the left main. It has gone into the circumflex and blocked off the circumflex, and patient has arrested. So these are the features that one has to be careful when dealing with large thrombus burden. And finally, the case that you were not getting any flow at all, and you went in and dilated with a balloon. You can do that, but do not start with a large diameter balloon. So do not start with a 3 millimeter balloon, because if you do that, then what happens is that the thrombus inevitably fractures and it gets disrupted everywhere. Take a 1.5 millimeter balloon and dilate it and keep it dilated there for quite some time. And what it does is it opens up a path within the thrombus. And after that, once you have achieved that, give tirofiban or I give integralin and I give nicorandil, and dilate the distal vessel, dilate the distal vasculature. When that happens, then you are in a much better position, and make sure that your ACT is okay before you proceed doing further things. Because in this case, when you're taking, and especially we use reused export catheters, they are themselves thrombus generating. Sometimes you're taking it out, putting it back, taking it out, you have done it 10 times, and it generates thrombus by itself. So be very careful. And the balloon that you're taking, I make sure that in ACS, my first balloon is always a new balloon. I do not use reused balloons in these cases because the balloons themselves generate thrombus sometimes. So I think these are a few points that that I have learned from my experience. And when you're dealing with this case, you can remember and try to modify according to your situation and do it. And these cases, Snehal, they were all different cases. They were not the same case. So you said in the end that it is the same presentation. Yes, the presentation is inferior wall MI, but each of these cases is different. They're not the same. As you experienced in that RCA, that RCA wouldn't open up. So in ACS, we always have this dilemma that should we aggressively predilate or not. In younger patients, it is more likely that it is a plaque erosion or plaque rupture, like in a 39-year-old man. But when you have crossed 45, in our part of the world, there is aggressive early premature atherosclerosis, and it is risky to just go in with stenting without preparing the bed. There is always a risk of causing slow flow if you do a little aggressive predilatation. But I take time and I assess and I try to predilate it as far as I think is safe before stenting. Otherwise, you can get this. But in the end, I think your result was quite good. So congratulations.
Sir, one question, because for your experience, sir, some operators are now doing in primary without not doing thrombosuction or not well dilating. They are just putting a stent approximately. They are presuming that the length of the lesions may be this and putting a directly stent. What is your experience and what is your take-home message for this?
I would not do that for patients who are above 50. Because these patients, they have fibrotic disease. They have fibrotic atherosclerosis where there has been a plaque erosion and where it has occluded. And you can get into, if the patient has crossed 60, I would never do it.
Sir, what is your clinical experience of below 50? How you will choose the size of the stents?
I would look at the overall coronaries. Okay, if the other coronaries are also diseased, okay, and it is a sort of, they're not critically diseased, but they're diseased, say 60-70% disease elsewhere. So I am dealing with an RCA, but I'm seeing that the RCA, the LAD and the circumflex and the left main, they also have moderate disease. That tells me that this is a long-standing case of atherosclerosis. I mean, this cannot be plaque erosion or plaque rupture. Whereas the first case that Snehal showed, it's a 39-year-old man. All the other coronaries are absolutely normal. And you have only a column of thrombus in the mid RCA. In that case, I would feel more comfortable to do it, to go in with a stent and stent it.
My question is that if you will not see the distal lesions, and that is totally.
No, you have to see the distal lesion. I do not agree with not the distal landing zone.
What I am telling you, I want to ask you that some operators are now doing it is a person just putting a stent in primary PTCA without pre-dilating, without export, and just putting a stent. What is your just? I want to ask.
I think if you do, I mean, those who are doing it, after they have done 50 cases, I think their outlook will change, because as we saw from this series of cases, these cases really they are not the same. There will be some cases where you can get into trouble. If you are suspecting a long column of thrombus and you cannot see the distal vessel, I would definitely not stent it. I would definitely.
Our classical teaching was without not distal. If you not see the distal lesion, there will be no stents.
Yes,
but now
exactly. I mean, I wouldn't do it. I wouldn't do it. It is not safe, and I mean, I think I can understand that people are saying that we do not believe in export, because the data of the export is a bit borderline. I think what it works in the type of lesion that Snehal Goswami showed. There is a large volume of thrombus. It is a really big artery. Diameter is 3.5 plus, and those cases, I think in one case he showed that there was a visible thrombus on export aspiration. I would go for export aspiration in those cases with the cautionary facts that I said, because you can get into trouble with export also. However, if I feel that export is not safe, or I don't want to do export, I would actually go in with a 1.5 balloon in totally occluded arteries. I'll do a gentle dilatation, and usually this results in recanalization of the vessel where you can see the distal landing zone. And after that, I usually give GP2B3 inhibitor and nicorandil, and I wait for 5 minutes, reassess the distal vessel, and then go on to complete my case.
Thank you, sir. Thank you. We have a good learning discussion from you. Any question from the audience? Any panelists or speakers also? Pranay, what is your experience?
Sir, one question I want to ask. So, anytime you are using intracoronary thrombolysis, either tenecteplase, STK, or other things in hypertension?
I have never used it myself, but I have seen some cases where there was no other way out of it. And I have seen intracoronary tenecteplase working in these cases. So if you have a case where, for example, there is a long stream of thrombus and there is no flow distally, and you have tried everything, meaning these techniques that I have said, usually what I have followed in these cases, the flow actually returns. I have never seen a case where the flow hasn't returned at all. But I have seen some cases being presented in national conferences where I have seen they're using intracoronary tenecteplase, and it results in recanalization. Usually, if once you have done it, in those cases, you should wait and not stent immediately, but bring the patient back in 48 hours or 72 hours, whichever is appropriate, and then redo the stenting.
Pranay, actually, I used to do a lot of primary cases, primary angioplasties. Usually in 100% lesion and good size vessel, I used to do export in maximum number of cases. And sometimes I did part type without thrombolysis. I used to give GP2B inside the catheter of expert catheters, and otherwise giving it in cutting balloon. I took a balloon, cutting balloon inside the coronary over the wire, and give GP2 inhibitors. And second, if the lesion in LAD, left system, I used to give adenosine. That is also a very good result. What was my experience? And third is usually in large RCFS and in thrombotic lesions, usually we don't, if you will do export also, I think we should leave without putting a stent. We should allow the patients to live for at least 1 or 2 weeks. Next, ask the patient to come and because whatever the literature says, if you will putting a stent in thrombotic lesion, the chances of basically a stent thrombosis is 40 times higher. In not doing if you just do a balloon and do a stent, the chances of stent thrombosis will be 40% higher in putting a stent. So my question, I think it is
I agree. I think where you have this doubt whether you are going to be able to post-dilate the stent, should it be necessary? The catch, the problem is that you have stented, the stent has not expanded fully, and you cannot post-dilate for the fear of causing distal embolization. That is the situation that you want to avoid. So that is the rationale behind doing this. So you give GP2B3 inhibitors, the flow has returned. So remember that in thrombolysis, what happens in 60% of cases is that the flow is TIMI2. From TIMI0, it becomes TIMI2. And the myocardium survives. And then you do something later on. So similarly, in these cases, if you have restored flow, for example, if there is TIMI3 flow, there is a residual stenosis with thrombus, then you can wait. And if you give anticoagulants, usually these vessels, they do not block off again. And then
what is your choice of antiplatelet or antithrombotic in whatever the snail shows the last cases? What is your suggestion? What you will prefer?
I always give integralin. So that is my choice.
What,
Eptifibatide.
No, sir, I am asking about the post-discharge patient.
Okay. And I mean oral antiplatelet.
Yes,
yes, it is. If there is a lot of thrombus burden, I would either give prasugrel or ticagrelor, whichever is more appropriate.
Thank you, sir. Thank you. It is a very nice discussion about thrombus.
Yeah, it is. I mean, thrombus is a very, very difficult problem. And, the more you do, the more you realize how you can get away out of sticky situations. The worst thing that can happen is that you have, I have seen patients die. So someone is doing a left anterior descending artery occlusion, large artery ectatic with a lot of thrombus, and he starts with thrombosuction and the thrombus goes into the circumflex. The circumflex is dominant, circumflex gets occluded and the patient just crashes on the table.
Left system thrombosuction, you have to be very careful.
So this
right
is
system, okay, but left is very careful.
This is something that can happen if your left main is, especially if it is a long left main, be all the more careful because there is more chance of thrombosis.
But one thing I think that result is excellent, and for operators, if you do a thrombosection, to get TIMI3 flow is very, I think.
Yes. I am in favor of thrombosuction. In fact, we presented a paper in TCTAP, an abstract about our view on thrombosuction and which are the cases that are suitable for thrombosuction. And I think what I am saying, a lot of it is in that abstract. So I am in favor of it. It is only that you have to be careful. Otherwise, these things can happen.
Okay, sir. Thank you, sir. Any questions or we will conclude? I think we can conclude. It was a very, very lucid discussion. Thank you all. Thank you, Bhattacharya sir, Dr. SP Sinha, DP Sinha sir, Dr. Ghosh sir, Dr. Malpani sir, Dr. Pranoy. You are very nice presentation, Dr. Rajas and Dr. Snail.
Okay. Thank you all. Thank you. Thank you to all the presenters. Thank you, Dr. Bhanja, and all my co-panelists. Thank you. Good night.